Good afternoon, students. Today's topic is chronic osteomyelitis and port spine. First, we'll start with the definition. To define chronic osteomyelitis, it is a severe, persistent, and incapacitating infection of bone and bone marrow. The etiological agents are usual organisms. With time, there is always a mixed infection. The commonest organism is Staphylococcus aureus, then Staphylococcus pyogenes, E. coli, Pseudomonas, and Staphylococcus epidermidis. Staphylococcus epidermidis is commonest in the setting of surgical implants. Clinical features are pain, pyrexia, redness, tenderness, and discharging sinus. Through the discharging sinus, there is seropurulent discharge. Now we come to the pathogenesis of chronic osteomyelitis. First, there is inadequate treatment of acute osteomyelitis or foreign implant or open fracture. Then the inflammatory process continues with time together with persistent infection by Staphylococcus aureus. Then the persistent infection in the bone leads to increase in the intramedullary pressure due to inflammatory exudates or pus stripping the periosteum. There is vascular thrombosis and necrosis of the bone, and there is formation of sequestrum. This sequestrum is known as the dead bone, and this is followed by formation of new bone, which is known as involucrum. So sequestrum is the dead bone which is surrounded by formation of new bone formation, which is known as the involucrum. And there are multiple openings appear in this involucrum through which the exudates and debris from the sequestrum pass via the sinuses, and there is sinus formation. In the diagram, the sequestrum is shown by the arrow, which is, and there is involucrum or the new bone formation is there. This is a diagram in which there is skin, drained sinuses, sequestrum, and soft tissue, in which there is chronic osteomyelitis involving the metaphysis of the tibia. Now coming to the radiologic findings, in the X-ray examination, usually show the bone resorption, thickening and sclerosis of this sequestrum and involucrum. There is radioisotope scintigraphy, and the investigation of choice is CT scan and MRI. The AP and lateral view of the left wrist show a lobulated osteolytic lesion with well-defined borders and surrounding sclerosis at the distal radius, minimal expansion, mild periosteal reaction, and soft tissue swelling are present. Now the complications are pathological fracture, deformity, shortening, or lengthening. Now we come to the port spine or TB spine. Now coming to the introduction. Skeletal tuberculosis is common in India. Vertebral tuberculosis is the commonest form of skeletal tuberculosis, more than 50%. Dorsal spine is most commonly involved, mostly seen in first 3 decades. Now coming to the pathogenesis of TB spine, will come in a stepwise fashion. First, the step 1. Bacilli from the primary focus through bloodstream reach the disc space. It is seen in the red color. In the infection's focus is seen in the red color. Now the step 2. Once infected, soft nucleus center and the fibrous annular wall weakens, decays, and collapse. This causes the disc to close, squeezing down on nerve root, causing pain. The step 3. The infection spreads to vertebral bodies above and below the disc. Now the step 4, the bone weakened by the infection collapses under the weight of the human body. Now the step 5, the deformed spinal column compresses spinal cord, producing functional impairment. Step 6, over time the deformed vertebral body heal and fuse. This may further compresses nerve roots, causing pain and neurological deficits. So in nutshell, the pathogenesis of tuberculosis of spine is osteoporosis due to hyperemia, ischemic necrosis due to peri and endarteritis, and the disease itself leads to destruction of the vertebra. This leads to collapse of the vertebra, and there is progressive deformity leading to kyphosis and deep bus. What spine? The spine, 40% especially the thoracic and the lumbar vertebra, followed by the knees and the hips are the commonest site of TB spine. The osteomyelitis leads to be more destructive and resistant to control because the less blood supply. In the spine, the infection breaks through the intervertebral discs to involve the multiple vertebra and extend into the soft tissue forming abscesses. Now coming to the clinical feature, pain on motion, localized tenderness, low-grade fever with chills, weight loss, severe destruction of vertebra resulting in permanent compression fracture that produce severe scoliosis and kyphosis, neurological deficits due to nerve compression. Complications are TB arthritis, sinus tract infection like any tuberculosis or in any other sites. Sinus tract infection is also common in TB of uh, TB of quad spine. Psoas abscesses and amyloidosis is also a late complication. Thank you.